Hey everyone, I am Dr. Shashikant. I am a professor in pathology, and today we are going to discuss briefly about the Crohn's disease. We are going to discuss the salient aspects of Crohn's disease. So, Crohn's disease is a chronic granulomatous ulcerative disorders, and it is inflammatory bowel disease that involves all the layers of the bowel, and it most commonly affects the small intestine, and the ileum is the most common reason to get involved. It tends to affect the people most commonly in second to third decade, and is common in certain races like Jewish people. It is more commonly being seen, and it has discontinuous distribution. That means intervening normal areas are seen amidst the diseased segments. The etiopathogenesis lies in abnormalities in immune regulation, host microbe interaction, and epithelial barrier function. Polymorphism of NOT2 has been clearly associated as a significant risk factor, and this NOT2 mutation is known to activate the NFK beta pathway. The role of Th1 Th17 activation has also been clearly defined. The microbial soluble products activate toll receptors and the NOT2, and that is again an important factor in the pathogenesis of Crohn's disease. So Crohn's disease affects small intestine in majority of the cases, and a few of the cases both small intestine and colon, and very rarely you will see that only colon will be involved. That is the domain of ulcerative colitis, not the Crohn's disease. Inflammation involves all the layers, so it is a transmural inflammation characteristically. It is it is sharply limited, and there is discontinuous spread. That means there are skip lesions, and the thickening of the involved segment occurs due to inflammation and resultant fibrosis. And radiologically, we get a characteristic narrow lumen, that is, string sign is being elicited in radiology. Focal mucosal ulcer or aphthous ulcer occur, which usually fuse to form linear ulceration or serpentine ulceration. So coming to the pathology, the gross appearance shows characteristic cobblestone appearance. So mucosa just surrounding the ulcers are usually spared, and they show edema and regenerative hyperplasia to become elevated, and there is a laminated brick-like appearance which is known as cobblestone appearance, which is very characteristic and which is in contrast to the pseudopolyp appearance in ulcerative colitis. The creeping fat occurs especially where there is severe transmural inflammation. In that cases, mesenteric fat wraps around the serosa of the bowel, and this is believed to be the short sign of Crohn's disease. It is one of the most specific sign for Crohn's disease. So please remember this. This is a very important vignette for you. Skip lesions, as we discussed, the normal intervening and the disease segment occurs, and there is usually a sharp demarcation between the involved and the uninvolved area are seen. Fissures in the mucosa and the anal fissures are a very common feature, and that penetrate the wall, and many of the times fistula or sinus tract formation occurs between the abnormal organs, between the different internal organs. So fissures, fistula, sinus tract, these are pretty common features of Crohn's disease. So as you can see in this image, there is a narrowing of lumen, and resultant thickening of the bowel wall is clearly being demarcated. And as you can see, the arrows pointing out to the serosal extension of mesenteric fat. And here comes the cobblestone appearance, the laminated brick appearance, the elevated mucosa. So that is very characteristic and usually seen in Crohn's disease. Coming to the microscopic feature, the majority of the cases shows non-caseating granulomas. So that non-caseating granulomas, which is in contrast to the caseating granulomas in various infectious disease like tuberculosis. And here you get transmural inflammation with the dense lymphocytic and maybe accompanied with a plasmacytic infiltrate as well. Pseudopyloric metaplasia, that is appearance of glands that mimic the architecture of stomach antrum, that is pseudopyloric metaplasia, and Paneth cell metaplasia may be seen in the left side when it is involving the left side of the colon, and the Paneth cell metaplasia can occur over there. So as you can see in the image, the dense lymphocytic infiltrate and the beautiful uh, multinucleated giant cells, and you can see the formation of a granuloma, the epithelioid cell clusters. So the clinical manifestations include the episodes of diarrhea with blood and mucus, and you get relapsing course usually with intermittent symptomatic and asymptomatic period. Signs of anemia with features of both iron deficiency and vitamin B12 deficiency can occur due to the involvement of ileum that leads to defective B12 absorption, and anemia occurs due to constant bleeding. And this iron deficiency anemia occurs due to constant bleeding. And extensive malabsorption and hypoalbuminemia can occur when there is extensive small bowel involvement that can lead to defective absorption of most of the nutrients. Calcium oxalate renal stone and cholesterol gallstones have been also found in increased number in cases of the Crohn disease affected patient, and this is believed to be due to increased oxalate absorption from the inflamed mucosa because of the uh, defective bile acid absorption, defective bile salt absorption from the inflamed ileum, and that results in uh, free fatty acids, and these free fatty acids combine with calcium, which is normally combined with the oxalate in the lumen. So now more of oxalate is set free, so which gets absorbed, and subsequently it gets filtered through the kidney and deposited in the tubules, and it forms calcium oxalate renal stones. Similarly, the excess of free, free fatty acid due to defective malabsorption, due to defective bile salt absorption from the ileum. So the bile is usually supersaturated with cholesterol, and that can lead to cholesterol stone formation in the gallbladder. So calcium oxalate renal stone and both the cholesterol gallstone can form in increased number in the patients of Crohn's disease. Complications. The complications include the formation of stricture, fissures, fistulae, perforation, and perianal abscess are also common complications. The extra-intestinal features are more or less the same as that of the ulcerative colitis. The cutaneous granulomatous nodule is an exception that is not seen in case of ulcerative colitis, but here it may present as a cutaneous nodule. Uveitis, migratory polyarthritis, ankylosing spondylitis may be associated with again HLA-B27. Erythema nodosum also forms. Pyoderma gangrenosum is rarer compared to that of ulcerative colitis. Clubbing of fingertip is also being seen, and pericholangitis and primary sclerosing cholangitis, uh, the incidence of these two entities, biliary tract disorders, are also increased, but it is much lesser compared to that of ulcerative colitis. Ulcerative colitis has a much stronger association with these biliary disorders. So the treatment modality includes the anti-inflammatory drug, immunosuppressive drugs, and anti-TNF drugs have been the cornerstone of therapy these days. Like infliximab like drugs, and surgical treatment of complications have also been routinely done to treat the complication. So thank you all for the patient hearing, and please subscribe to this channel and put a bell icon for the notification, and also put in comment what kind of videos you would like to hear in future. So thank you and see you all in the next video.